This is an EM Pulse miniseries, Push Dose Pearls, with your hosts, Sarah Medeiros and Julia Magaña.
Welcome back to an episode of Push Dose Pearls. Push Dose Pearls is our ongoing series of brief podcasts that address the questions we all have regarding medications in the emergency department. And we are here with Chris Adams, our own ED Clinical Pharmacist at UC Davis and EM Pulse Pharmacist. So today we're going to talk about a topic that is near and dear to my heart, anticoagulation reversals in the emergency department. Just kidding. I never use these. I only take care of kids.
Yeah, but I see this all the time, and I think this is super important. I mean, I remember back in residency where we would have patients coming in as a trauma, for example, ground level fall on blood thinners. This is a pretty common thing that we see. And our neurosurgical team would kind of look at the patient, and if they were on Coumadin, it was like, okay, we can start vitamin K, we can start all these things. If they were on dabigatran or one of these others, it was just like, oh, sorry, comfort care. There was nothing that we could do. Now we do have some more options.
Okay, that is pretty cool.
This is an evolving area. With anticoagulation in general, there's a huge volume of patients, an ever-growing volume of patients that are on these oral anticoagulants. Warfarin is obviously the historical choice, but the newer agents such as Xarelto or rivaroxaban, Pradaxa or dabigatran, as well as Eliquis or apixaban are extremely common within the community and are continuing to be utilized more and more frequently. And these patients are at an elevated risk of significant bleeding, especially in a setting of trauma. So it is a very important area to talk about.
I am so impressed at how both of you said those names so easily.
I think I said it wrong.
I didn't even know. Okay, so it's not just vitamin K anymore, right? What are the anticoagulant reversals that we can use in the emergency department?
That's right. Vitamin K certainly still has a place in therapy, but it is generally not considered your emergent reversal agent. So there are several different options, and depending on the institution and practice setting, you may have significant differences in practices. So first of all, we have Kcentra. Kcentra is a 4-factor product that provides reversal for anticoagulation generally with warfarin. You can also use Kcentra for the potential reversal of other newer agents such as Eliquis, apixaban, dabigatran, Pradaxa, and your Xarelto or rivaroxaban. In addition to that, there is another 4-factor product on the market that does not have FDA approval for reversal of these agents, but is commonly utilized. It's called FEBA. So FEBA is an older agent that was used in the treatment of hemophiliacs that had significant antibodies associated with their factor products. And so it was a way to almost bypass those antibodies that they had built up over time. So FEBA is, again, very similar to Kcentra in that it's a 4-factor product, but does not carry an FDA indication for reversal of these anticoagulants. And finally, the last agent on the market that is, depending on your practice setting, may or may not be available is andexanet alfa. Andexanet alfa is not something that I'm familiar with utilizing because we just don't carry it in our practice setting. However, it is a direct-acting true reversal for these new oral anticoagulants.
So I mentioned the head bleed, but let's talk about some other clinical scenarios where you really might need to emergently reverse an anticoagulant.
So this is dependent on how severe the bleeding is. If you're considering a bleed to be a life-threatening scenario and a patient is on an anticoagulant, in those scenarios, you most certainly should be considering the use of a reversal agent. So tricky ones might include GI bleed. Severe GI bleed in a patient might potentially benefit from the use of a reversal agent if they're on oral anticoagulant. However, they also really need volume. They need blood. And so it's kind of challenging whether or not a reversal is absolutely indicated in all of those situations. But if you have a hemodynamically unstable patient who is clearly ill and potentially decompensating and potentially going to die, reversal of that patient who is on oral anticoagulant may be indicated. Other scenarios may include urgent or emergent procedures that need to take place that may be contraindicated because of an oral anticoagulant. So if a patient needs to have a potentially significant operating room procedure and they're on oral anticoagulant, that's another area where several of these products have an FDA indication for emergent reversal of their action.
And how fast do these usually work?
These are extremely fast. So generally speaking, these agents are considered to work immediately upon administration. A little bit of redistribution after the fact is probably important to ensure that you have the full effect of the agent. However, immediately upon administration, you can consider them to be working and to have provided the benefit if they're going to provide anything at all.
Wow, that's really fast. And how long does it last?
Depends on which agent we're talking about. So with Kcentra, Kcentra is that 4-factor product that has factors 2, 7, 9, and 10. So there are several different agents within it, and each one has a different half-life. So factor 7 has the shortest half-life, and therefore it's considered to have a duration of action of somewhere in the range of 20 to 24 hours of activity.
And do we need to think about the fact that this patient was on an anticoagulation for an important reason to begin with? So, is the patient going to suddenly have a clot and a stroke because we've reversed this medication?
It's certainly an important consideration. If you have active clot, if you have a patient who is suffering from an ST elevation and needs to go to the cath lab, and the cath lab is concerned about their oral anticoagulant, giving a procoagulant such as Kcentra or a reversal agent on top of that may actually cause more clot burden. So you actually may cause more harm than good in those situations. For a patient who is suffering from a relatively recent DVT or PE, certainly, again, a consideration if you, again, want to give a procoagulant, this reversal agent, that may, again, cause potentially more clot burden. So certainly a consideration. However, in the majority of healthy patients that are presenting, that are on oral anticoagulant for prophylaxis of a thromboembolic event, such as AFib, in those patients, somewhere between 3 to 4% of patients will develop a VTE or venous thromboembolism after administration of Kcentra or a procoagulant. So in these cases, there certainly is a risk associated with this medication. These aren't benign medications, obviously. However, there is potential benefit. Potential is important here. We don't have clear evidence that suggests these reversal agents change outcomes. So in general, there is no data that suggests that patients have a lower risk of mortality when we administer these medications in a life-threatening bleed. There are some caveats to that. And we know that administering it earlier does generally result in a lower risk of bleed expansion. However, we know that mortality does not change regardless of whether we give these medications or not.
Whoa, that's kind of huge, isn't it?
Yeah, and one of the hardest ones that I always have is, for example, the patient who has a mechanical valve. I mean, is there any way to sort of semi-reverse these anticoagulants?
That's a relative term. Semi or partially reversing is certainly not a common practice, but we will give smaller doses or empirically adjust the dose down if they have a higher risk of a thromboembolic event. In the situation you're referencing, a patient who has a heart valve certainly may be at higher risk, and we may consider a lower dose of one of these reversal agents.
Yeah, and that's interesting with the data you mentioned. Is it worth it? Is it really going to help them out if I'm reversing their anticoagulant, or am I just going to cause them more problems?
In a situation where a patient is going into the OR for an emergent procedure, absolutely. Of course, we want to ensure that the surgeons are going to be successful in the OR by providing this reversal to an oral anticoagulant. So getting them to the OR, getting them definitive care facilitated by these oral anticoagulants is certainly of benefit to patients. Question is there clear evidence that it's not worth it? Are we sure that this isn't providing a benefit to the patient? And I don't think that we're there yet. I don't think that there is adequate evidence to suggest that there isn't a benefit here. There might be, and we just haven't actually identified it with the clinical research that's been done. However, it's hard to say to a loved one we didn't reverse the INR because there's no clinical evidence associated with it. Of course, we're certainly going to improve their ability to clot a significant bleed, but it's just not clear whether it really is helpful to patients. In the current state, guidelines certainly recommend that we reverse INR, reverse these oral anticoagulants, but it's just not clear what benefit we are providing.
Interesting. Chris, anything else you think we need to know about this?
For those practicing in institutions that utilize andexanet alpha, it's a very challenging agent to utilize. It's hard to know what place in therapy this agent has. It's a very short-acting agent. So we provide this anticoagulant reversal, and it only really lasts for a couple hours. We're talking like 2 to 3 hours of duration. But then what happens next? What do we do after we administer that medication, after the patient comes out of the OR having suffered from a traumatic brain injury? It's really unclear what role andexanet alpha has to play. And for those using Kcentra, don't forget about vitamin K. Vitamin K, as we talked about, is still an option, still something that we should be utilizing. As we noted earlier, there's really only roughly 20 to 24 hours of action associated with agents like Kcentra or FIBA. And so after that medication has worn off, after the INR starts creeping back up, then what? Well, that's where vitamin K comes into play. We really should be administering vitamin K in addition to Kcentra. That provides a kickstart, if you will, to our own endogenous production of vitamin K-dependent clotting factors. So those clotting factors that warfarin inhibits, 2, 7, 9, and 10, we want to jumpstart our own production of those so that way INR doesn't creep back up after that 24-hour period, after that Kcentra starts to wear off. So vitamin K in those patients that you want a continued reduction in their INR, continued reversal, make sure you're giving a little bit of vitamin K up front.
Okay, so that was really nerdy, but thank you, Chris, for walking me through it. I think I have a better idea now about the use of anticoagulants in the emergency department.
Nerdy is a pharmacist's specialty.